Good morning. My name is Jason Brooks with the SRS podcast, and I am so excited about our episode today because it's about a topic that is near and dear to my heart, and that is humanitarian work. Today, we're going to be highlighting a podcast episode with Dr. Michael Heffernan representing the Global Outreach Committee, and he'll be interviewing Dr. Richard Schwend, who has dedicated much of his life and career to helping children, not just in the United States, but all over the world. So stay tuned for an amazing conversation.
My name is Mike Heffernan from Children's Hospital New Orleans and the LSU Health Science Center. I had the opportunity to interview Rick Schwend in relation to his global outreach work. Rick is currently at Mercy Children's Hospital in Kansas City, where he is the interim chair of the Department of Orthopedic Surgery. He is also the director of the Pediatric Orthopedic Surgery Research Program there. He is past chair of the American Academy of Pediatrics section on orthopedics, also past president of the Pediatric Orthopedics Society of North America. He's a professor of orthopedic surgery. Related to our topic of global outreach, he received the Humanitarian Award for Service from the Pediatric Orthopedic Society of North America in 2014. And he also received the Walter P. Blount Humanitarian Award from the Scoliosis Research Society in 2018 for his work in Ecuador. This interview covers a wide variety of topics, including aspects of Rick's life, his thoughts on balancing family and medicine, as well as his efforts in global outreach. The beginning of the interview focuses on his training and career, and as we move into the second half of the interview, there's a specific focus on global outreach, specifically his unique experience working with his colleagues in Ecuador to build a spine deformity program from the ground up. I really enjoyed my conversation with Rick, and I hope that you find it interesting as well. Rick, thanks for joining us.
Thank you, Mike. Good to be here.
Let's start by having you share a little bit about your upbringing and maybe what you were like as a kid.
I was born in Hollywood, and we lived in Los Angeles when I was young, and then we moved to Long Beach, California.
You went to school all the way up through high school in California?
Yeah, through college. So then we moved to Thousand Oaks, California, and I went to high school there, and then I went to the University of California, Santa Barbara for college. So really my parents were my role models. My dad was an engineer, hardworking. Every male I've ever met in my life was an engineer. He would bring home his engineer friends, and I just assumed adult males were engineers, and that was what I was going to become. And it wasn't until I got to college that I realized I could do, something different.
What was your major in college?
Biochemistry, and so it wasn't engineering.
So were you still thinking that you were going to be an engineer at that point, or what?
No, I didn't know what I was going to be, but I wasn't going to be an engineer. I didn't want to do what my dad was doing. I was kind of rebellious. My mom was the valedictorian of her high school class, and that really impressed me when I was growing up. She would always say, "Oh, I was a valedictorian. You could do well too."
So let's say elementary, middle school. Were you academic at that time?
I was always a good student because I was kind of well behaved and respectful of authority. But I went to a very nice public high school, and I had really good teachers that influenced me. We didn't have a lot of money growing up. Thought if I was going to get to college, I needed to get a scholarship. I think that kind of motivated me to be a little bit more academic than I would have been.
You got an academic scholarship?
At the University of California, you could get a university scholarship to one of the campuses, which I got to go there. And then I got a California State scholarship as well. And so really, I didn't have to pay for college.
Did you play any sports, or what were your activities when you were a kid?
Baseball and football. So half the year was baseball, half the year was football. I didn't understand basketball because we didn't have basketball courts.
And what were your college years like?
They were great. I was at University of California, Santa Barbara, so a beautiful campus on the beach. I thought it was academically, it was kind of the right mix for me. I did a lot of volunteer work in college also. I started getting into some of the different volunteer opportunities that were at the campus. And so I think that maybe helped me a little bit with some of my interest in helping people. Same thing with, when you decide to be a doctor. Initially, you kind of do it because it seems like a good thing to do. And then at least I started out wanting to save the world as going into medicine. Quickly, you realize that it's probably better to just want to help people and not really necessarily change the world.
When did you decide to go to med school?
Probably about halfway through college. I remember I had a friend, she was struggling a little bit, but she really wanted to go to medical school. And we were in the same classes. I started tutoring her and started getting better at her classes and was doing really pretty well and was determined to go to medical school. And I think in just that whole process of helping her, I started realizing that I could do it also.
So up to that point, you were all California growing up.
Yeah.
And then you went to med school at St. Louis University?
Yeah, I went to St. Louis University, a nice Jesuit school. We were all Catholic growing up, so that was a good fit for me. Jesuit. It's a little hard to get used to St. Louis when you've lived in California your whole life. It's like I couldn't believe people lived like that. Like, how could people live in such heat in the summer and snow in the wintertime? It was like snow was something you visited when you wanted to go have a good time. But I met my wife there, and we're still together all these years later.
How many years have you been together?
40-some years, 46 years. I don't know, it's a long time.
Amazing.
Yeah. So we have 2 kids. I have a son in Seattle. He's a pilot in the Army, and we have 2 grandchildren there. And my daughter lives in Kansas City with us, and she's an art teacher.
Did he follow in your footsteps? Because I saw you were in the Air Force as well.
Yeah, my dad was a pilot in the Army Air Corps in the Second World War. He was a B-24 pilot, and so he flew heavy aircraft. And my son was always impressed with that. I think it kind of influenced his decision to join the Army and fly. And so he flies the Chinook helicopters, those big twin rotor aircraft. He just got a job a few years ago with Alaska Airlines, so he flies with them now.
Now back to your career. When you were in med school, when you first entered, what was the plan?
What I always thought I would do is be some sort of like missionary doctor. And I didn't know what that really meant. And so about halfway through medical school, I ran out of money and I was able to get a scholarship to the public health service. And so I had a 2-year scholarship with them. And so what I was going to do was join the Indian Health Service after medical school. And then I would do that for a while. And then I wasn't sure what I was going to do after that. I was thinking primary care, just being a general doctor. Towards the end of medical school, I decided I wasn't quite ready to just go off and start working. I wanted to get some training. At that time, if you wanted to go to residency, you can only do it in primary care before you're doing your service obligations. So I did an internship, and then I did my training in pediatrics.
Out of med school, you did a residency in peds first, and then you were in the health service.
And then I did my health service obligation. So I did that for 3 years. We were in Zuni, New Mexico on the Zuni reservation and was a general medical officer.
I mean, it's a little fascinating that, you know, on the one hand, you're in med school and it seems like you're making these decisions like, okay, this is just what I'm going to do for the next year. And then I look at you so many years later and you've been the president of the section of orthopedics for the American Academy of Pediatrics, the president of POSNA. And, you know, for someone that was just sort of like winging it at the time in terms of like, let's just take this next step. I mean, your career has then blossomed within pediatric orthopedics to something that's really unbelievable. So how did that occur?
Well, one of the things is what influenced my parents. Like my dad was like exceptional at what he did. He was like a really well-known engineer and very accomplished. And I think that was one of the reasons I really didn't want to like follow in his footsteps. I didn't think I could ever do what he did. But I think I got from him kind of this interest in doing things really well. And so I've always been real passionate about doing a good job at things. But my problem has always been like choosing the right thing to do because it's always been kind of whatever I feel like doing at the time. Oh, I forgot to say, like when I was a senior in medical school, I wanted to go overseas somewhere. And, you know, a lot of people want to do it nowadays, but back then it wasn't well received. When I talked to our dean, I really had to make a justification to go as a medical student to do a couple of months overseas. But I did get a fellowship in doing this. And so my wife and I went to Liberia. Back then, Liberia was a pretty bad country. And I got to be exposed to some really good surgeons working there, doing really good work in that country. And that really impressed me very deeply about, you know, what you can do. And the importance of surgical services internationally, because, you know, the global burden of disease, there's a lot of interest now in surgical care, but back then it wasn't such an obvious need. So I did get that experience, and that was because I had a passion. I wanted to do it. I don't know where it came from. I just wanted to do something like that. But when I actually had the experience, then I had these tremendous mentors and people influencing me that I think made a difference later in my career as far as what kind of things I would want to do.
Were those the surgeons from Liberia or people
That was what really impressed me. They were local Liberians that both of them had come to the United States for their training and both chose to go back to their country to work. And so that was early in my career, learning that lesson, how important it is to have local people well-trained that are passionate about going back and taking care of their own people.
So what do you think the key thing you learned from Liberia was?
The thing in Liberia, there was a lot of death and dying. I kind of appreciated how, when you hear about infant mortality and early childhood mortality, and I saw it firsthand there, what these people have to live with and why it's so difficult to provide surgical services to poor countries because they don't have the infrastructure. I happen to be working in a missionary hospital that was fairly well established and supplied, but still were missing a lot of stuff just because of it's was far into the country. And I guess I learned how fragile life is in that setting. But I also learned from the two surgeons that were there just the dedication that some people could have in their careers. I mean, these people were giving up a lot to go back and serve their people. They weren't getting paid a lot. So,
at that point, were you thinking of doing that type of work full time?
I thought it would be kind of neat to do that as a career, but that was kind of far away because I had to go back home and then start training. But I hadn't really kind of formulated a long-term plan based on that experience. It was more just, I think it helped influence some of how I perceive things in the future.
At that point, you were still in medical school, hadn't decided on orthopedics yet. How did that occur?
When I started thinking about orthopedics is when I was out in the Indian Health Service. I always assumed after I did my obligation, I was going to go back and do some sort of subspecialty. And I had 3 years on the Zuni reservation working with the people there. I had 3 years to just be a doctor and see what I like to do. And I don't think people often have that same time to experience that. We had a maternity ward. We were involved in delivering babies, and we were taking care of trauma in the emergency room. I started doing a lot of orthopedics. People come in fractures. We, reduce their fractures and put casts on. We didn't have any orthopedic surgeons. And femur fractures, same thing. And I started enjoying that. I found that of all the things I was doing, that really enjoyed it. And I thought, well, with my pediatric experience, that peds ortho would probably be the right fit for me. And that was when, after 3 years of doing that, when it was time to go back and do some sort of fellowship type of training, that's when I decided, well, I want to do orthopedics. And everybody said, that's a lot of work. I wouldn't, why don't you do something a little bit easier? And my wife said, I can't live with you if you keep talking about it. You got to just do it.
Sounds like good advice.
Yeah. And so I took her advice. I decided, okay, I'm going to just do this. And so I, applied to orthopedic training, and it worked out.
Well, you just happened to go to residency at Harvard.
When I was on the Zuni reservation, we had a program with Harvard University. We would take their medical students, and they would come and they would spend a month with us as an elective. And we would work with them. And then I got to know their faculty who was running the program. And so we ran a really good program, and there was a lot of medical students that really wanted to come. So I was getting good letters of recommendation from their faculty and stuff. And so it was time to apply for residency. I think they had a big influence on putting a good word in for me. When I was there, I was the director of the hospital. We started a dialysis unit because of the kidney disease that was in the population. We started a community health program for diabetes. We were the first hospital in the government system, like VA, military, to become non-smoking. We just decided we're going to not be a non-smoking hospital. That was when we weren't supposed to be able to do that, and we just did it. We were doing a lot of good stuff.
And you stayed in Boston for fellowship, so you were there 6 years?
So back then, it was 3 years of ortho school,
okay.
1 year being chief resident at Children's. And my wife was working in the developmental center at Boston Children's with Terry Brazelton's group. And she really, really liked it there, and she didn't want to leave. And I know fellowship training is different now, but back then, my fellowship interview was Dr. Hall came up to me in the hallway, and he goes, Rick, your wife and I have been talking about you, and we both decided that you're going to do your fellowship here. I said, okay, that's great, Dr. Hall, thank you. And that was my interview for fellowship. I don't know what Dr. Hall saw in me, but he saw something he liked, and he really took an interest in me. And it really was profoundly life-changing to have somebody of that stature see something in you that you don't even see in yourself.
What are some of the things that you took from him?
Oh, so just so much, just his his honesty. If he made a surgical mistake or something, he was just so honest with himself. His attitude was perfect will do, which really resonated with me because that was the same thing I grew up with. And then just kind of work-life balance, which I didn't really catch on right away to, but his attitude was, well, when you're at work, really be at work. And when you're home, really be home. And keep those two separate. And work is good, but home is better. And then after I left Boston, I kept in close touch with him. I would send him cases. I'd talk to him on the phone. I visited him a couple of times when he was retired up in Toronto.
It sounds like he was a big influence on you.
Yeah, I think that's why I got interested in spine surgery. It was hard to separate out his influence on me versus the spine stuff. He had such a command of spine, and that I always thought that spine was probably one of the more challenging things in peds ortho. Of course, now I learned that it's more the hip.
When you said balancing being present at work when you're at work, being present at home when you're at home, you're an accomplished guy. So how throughout your career, how has that ability to sort of fulfill your commitments in both places in an excellent fashion, how has that changed? What have you learned? What have you struggled with as somebody that's, younger in that? It's a constant struggle, I would say.
Yeah, that's really tough. I got a phone call from Jack Flynn one day, and he goes, Rick, the nominating committee selected you to be the opposing president. I just was so clueless. I didn't know what that meant. So I told my wife, like I usually do, I talked to my wife. I said, they want me to be opposing president. It sounds like a lot of work. And she goes, well, it is a lot of work, but nobody turns that down. And I said, well, I could turn it down. And she goes, do you really want to be known as the guy that turned down the opposing presidency? She goes, that's so weak. And she was like shaming me. And so her attitude was about the opposing presidency was, it'll make your life richer and you'll have more relationships in your life and you'll be that much better off for it. Just do it, but figure out a way to also be home.
How do you figure out a way to also be home? Because, there's only so many hours in the day and there's a lot of commitments that we make at work.
I wasn't chair of the department then. Brad only was. I told him, Brad, they want me to do this job and it's going to take a lot of time and I'm going to have less RVUs and some other people are going to have to pick up the slack here because I can't carry on my clinical load at the same time. So I had a big discussion with him, and I was fortunate to work in an environment with good people that were willing to see the value in the work I would be doing in that role. That helped a tremendous amount where they gave me permission to do this and they were willing to pick up some of the other work. Because it does take, those kind of commitments do take a lot of time. And I think everybody thought, well, maybe it'll make, we could start having people like me in leadership roles. It might help our reputation as a department. We want to keep improving. So that helped. But it was still a lot of you come home and, spend time with my wife. And then before I go to bed, still have to answer a lot of emails.
So does that mean you try to get some of that extra work done after everyone else goes to bed? You wake up in the morning early? What's your routine?
I don't feel like I'm any expert, and I feel like I've been a failure in work-life balance. But I try to have a bedtime. So at 9 o'clock, I try to shut it down. So knowing I have a bedtime makes me, hurry up and get stuff done before 9. And I don't like to let people see that I'm emailing late at night because I feel like I'm giving them the bad message that I'm staying up too late. So I try to just shut it all down at 9 if I can. And then between 9 and 10, kind of get ready for bed, take a shower, read a book or something. And if I can get to bed by 10, ideally, then I get up at 4:59 in the morning because I want to say I get up before 5. And then I ride my bike to work pretty much every day if I can. And that's my exercise. So that saves me some time not having to go to the gym. If I could ride to work, then I can ride home. So then I get to work about 6. And generally, I have about a half hour to get some work done, answer emails, make calls if I need to, whatever needs to be done. And then, of course, during the daytime, I'm usually working pretty hard when I'm at work, answering emails, talking to people, meetings. I don't really spend and time just hanging out.
Well, it's interesting because what I find to be the hard part to balance is not so much the clinical work or clinical volume, because that's an easy decision that requires 100% attention. It's all the extra stuff that, making decisions about what to do and what not to do and how to spend your time with the non-clinical academic work and balancing home life. I think that as a younger person, that's one of the things that I find to be constantly a challenge.
The other thing is my kids are grown up now, but when your kids are young, they really need you. They're not so much interested in quality time. They just want quantity time. They just need you to be around. And, there was times like when I was an ortho resident, my daughter was born. And so that was kind of tough because you just don't have the time. And so my wife, she was carrying a bigger part of the load, and she was working also. And so she's been tremendous. I've been very fortunate with her. And then, of course, my son, young when I was an ortho resident, and, I would just desperately try to find as much time as I could. But there's never enough time. And then you kind of hope that maybe by providing some financial stability, it kind of gives them at least that positive part of your life.
And now that you look back, if you were to advise me or another young person, what mistake and or advice, doesn't necessarily have to be a mistake, but what would you change? What would you advise me if I have a 2 and a 5-year-old, or for anybody who's listening that's has some younger kids? Like, what's the advice? Because obviously we want to be excellent work and we want to be present for our families.
I think the thing is, if you got young kids, my advice would be to make sure that you give your spouse some time where you're taking care of the kids, and just showing that you're making an effort, taking the kids, letting her go with her friends for a weekend, and you just take care of the kids or whatever it is, so that she just knows that you care and sees it. I've been very fortunate because my wife is so much better than I am with all this stuff. She runs the household. She takes care of she's so much more capable and so much more responsible than I am, that she's enabled me to kind of do this kind of work. And she sees the value of what I bring also. But the other thing would be to get a really good spouse and don't get divorced.
Sounds like a bad idea. So, and in terms of your career here in the States, so you left Boston, and where did you go after that?
After Boston, I wanted to have a career in the public health service. I still had this interest in that. I went back to Gallup, New Mexico, and as a commissioned officer, I did the orthopedic surgeon on the Navajo reservation. Worked with a guy named Bill Pratt, and Bill and I were the 2 orthopedic surgeons for about 300,000 in northern Arizona. So I did that for 3 years. What I really wanted to do is I wanted to start a pediatric program for Native American children, and so I had been talking to the Indian Health Service for a while, the leadership there, and they seemed to want to have that as a program. And so we started a clinic up in Shiprock, New Mexico, and we had some outreach clinics on the reservation. And then we had the medical center in Gallup, and so I was doing peds ortho then. And then also general orthopedics as well, just everything else that came in, because I was on call a lot. So that was an interesting experience working for the public health service as an orthopedic surgeon.
How long did you do that for?
I did that for 3 years. I was getting a little frustrated, and I talk about failures. This was one of my regrets in my life. I thought I was going to be able to make something out of this and develop a program, but it was very frustrating because it's hard to develop programs when they're cutting programs. And so at that point, they were really not interested in developing new things. They wanted to kind of slow things down. And so although I got a good experience out of it, and working with the Native American people was great and lovely, I got frustrated that I wasn't going to develop the pediatric orthopedic program I was kind of envisioning. And for instance, we had no capacity to do spine surgery, and I had a real interest in spine surgery, but we just didn't have the ICU set up and all the other things that we needed to do it safely. After 3 years, I realized I couldn't make it happen.
And then where did you go?
So I was kind of wondering what was I going to do with myself, because I didn't think I was going to continue doing this job. And then I got a call from Bob Gillespie. He was at Buffalo Children's Hospital. He had talked to Jim Castor and was looking for a person, and Jim had recommended me. And so Bob called me up and said, Rick, I got a job for you. Would you like to come to Buffalo? And I said, I don't know, Bob. You know, my wife had met him before, and he was very charismatic and dynamic, very convincing person. And so I had a long talk with him, and after I hung up with him, Colleen, my wife, goes, who was that? I go, it's Bob Gillespie. And she goes, oh, he wants you to come to Buffalo, huh? And I go, yeah. She goes, we're going to move to Buffalo, aren't we? And I go, I don't know. And she goes, I could feel it. So we moved to Buffalo to work with Bob, but work with Bob. But Doug Armstrong was there, and he was a great person to work with. So it was a good thing for us at the time. I was getting a little burned out from working too hard and not having any mentors really at that stage of my career. I was really feeling the need for something a little bit more than I was getting in terms of growth in my career. And so I think Bob came at a good time for me.
And how long were you in Buffalo?
So I was there till Bob retired. So I was there for 5 years. That was my agreement with Colleen. She didn't want to be in a place that she was going to grow old where there's a lot of snow all year round. I kind of told her when we got there that we would stay as long as Bob was working, because Bob was really a great mentor for me.
What did you learn from Bob Gillespie?
So Bob was like a really, really critical thinker. And, he had trained up in Toronto, and he knew all the people up there. He knew Salter and John Hall. So he knew what my training was. And I'll give you an example. We'd have indications conference, and he'd ask me what I thought, and I'd say, well, in Boston we would do it this way, or in Boston we would do it that way.
Right.
And one day he got really sick of that, and he goes, Rick, I don't know if you noticed this, but it's not Boston anymore. You're going to have to figure out what to do here. And he goes, besides, they don't even do it that way in Boston anymore. And he was very, very practical, and just like, wanting me to think for myself, think problems through, and not do something just because, that's the way you're trained, or that's what the literature tells you to do. But, really think hard about each child, what the child's needs are. And so I learned a lot about, spine surgery from him. He was a master at limb deficiency. And so I would go to the limb deficiency clinic with him and just watch him see these kids with all kinds of prosthetic needs. It was like an extended fellowship for me, at least. So that was great. Oh, he also asked me to travel. So he would want me to go around traveling, visiting people, just to learn from them. That was helpful.
And when did you start focusing on spine?
So I had an interest in spine, but I really didn't have much exposure to spine during the 3 years I was in Gallup, other than just taking care of spine trauma. And then when I got to Buffalo, Bob was backing off from his spine practice, so I got to take care of a lot of his patients. And so and I had a real interest from fellowship with John Hall, and so I started taking on more spine work with Bob Gillespie, and so he helped me kind of reestablish myself with the spine interest. I joined SRS then, and I started building up my experience with spine.
What was the next stop after Buffalo?
So we got one more stop. My folks were living in Albuquerque at the time, and we'd made some good connections the 2 times we've been living in New Mexico. And so I took the chief job at University of New Mexico at Carey Tingley Hospital. That was in 2000. So we left Buffalo, and because we had friends in New Mexico, and my family was there, and so it was a good fit for us to go back. So we moved to Albuquerque in 2000, and I took the job at the university.
Up until this point, were you still doing international global outreach work, or was there a period where that was kind of quiet?
When I was finishing my fellowship, one of my staff people, Peter Waters, was asked to go to Romania after the communist regime failed. And Peter asked me if I would go with him for 2 weeks and do hand surgery for kids in one of these orphanages. And I said, sure, I would go. And so he took me there. And he said something really profound. He goes, what I'm doing for you right now, or with you right now, I wish somebody would have done for me when I was earlier in my career, to take me to another place and give me this experience. And so that really kind of struck me as something really important, is how you can make an influence on young people, but just by giving them opportunities. Just for 2 weeks, we just did hand surgery together, and I learned a lot from him even those 2 weeks. I continued going back for several years to the same program in Romania. At that point, I kind of realized I do enjoy this kind of work. It wasn't really a program. It was just an annual visit we would do and do surgery. And the goal was to try to get these kids in better shape so they could get adopted out of these orphanages. So it did have a purpose in mind. I did that for a while. When I was with Bob, we had a program with the folks in Bosnia after the war there. And so we would go to Bosnia and help them with some of their program development. They were trying to develop a spine program. And so I got to go and visit there. So I continued over the years kind of doing international work. It wasn't until I had gone back to New Mexico in 2001 that we started doing the Ecuador program.
How did that come about?
So, Mike, just like the rest of my life, it was just kind of random. Because when I left the public health service, I really had, just like my father had been a career military, he was a major in the Air Force, and he's continued as a reserve pilot. I kind of figured I wanted to be in some sort of military capacity. And so I joined the Air Force as a reservist. And it was great. I had my reserve unit was in San Antonio at Wilford Hall, and I became part of that staff there. And so after the 9/11 happened, they were calling up a lot of reservists, and I got called up, but I didn't have to go overseas. I just went to San Antonio for a year, and that was my assignment as a lieutenant colonel in the Air Force. And while I was there, they had humanitarian missions that they would do. And so I got asked to do this humanitarian mission to Ecuador. And so I said, sure, I'll do that. And so we went to the Naval Hospital in Guayaquil in 2002. And the thing they wanted us to do was to just work with this one program that had a lot of kids that needed orthopedic surgery. So we went and we met the director of that program, Sister Annie, who was finding kids all over that part of Ecuador that needed care. And so we did surgery with the local people in the hospital. And I thought it was just a one-time thing. And then at the end of the trip, she goes, you got to come back and we got to make a program out of this because she's got hundreds of other kids that need help. And she'd already identified them, but she had nowhere to get care for them. And so the next year, we decided we'd come back. And so we planned for the next year. And then, of course,
at that point, who was we?
Oh, Project Perfect World. That was the group that had been involved in the humanitarian trip the first year to the Navy hospital. The Air Force was involved kind of as doing the transport and some of the logistics of it, but the NGO that was involved was Project Perfect World.
Okay.
Who had a presence down there, but they really didn't have a good program for children because it hadn't been developed yet. They were just kind of exploring doing, orthopedic care. They were doing like total joints for people, for adults and stuff, but they didn't really have a pediatric mission yet. But then with Sister Annie, I think we were able to focus it on children. And so we had a long discussion with her, and she was the one that was really the force behind us coming back, working at the Children's Hospital instead of the Navy Hospital. And when we came back the next year, we worked at the Children's Hospital. The staff doctors, they were awesome. They just said, oh, you got to keep coming back here. We got to keep developing. So all of a sudden you see this opportunity that's there. The people at the hospital wanted it. Sister Annie had all these children that needed it. The NGO group was looking for a program that they could, support, and it was just a matter of putting it all together. So it wasn't really, I didn't have any big vision of anything because I was just like thrown into this mix, which was great.
And what was the relationship with the physicians from the Children's Hospital there initially? Were they welcoming, distrustful? Were they kind of, suspicious a little bit, or, open arms, let's go?
They were like really welcoming. I was so surprised. Like, for instance, like the first year we had a clinic on Sunday, and there was like hordes of kids that had been identified that needed care. The whole orthopedic staff came on Sunday and did clinic with us, which would be kind of unheard of because they realized that these children couldn't get in unless they could be funded. The hospital wouldn't just let these kids get free care. They had to be supported. And so the Project Perfect World was willing to fund the kids. And so it was good for the hospital. It was good for the doctors because they had no way of taking care of these kids without some sort of support. And a lot of the surgical cases were kind of challenging to them in terms of their experience and expertise, because a lot of what they did was heavily trauma related, less reconstructive. Like things like hip dysplasia, they didn't have a lot of experience at it. And so they were very willing to partner with us and learn from us.
What kind of cases were you doing when you first went?
So the first couple of years, it was a lot of clubfoot surgery because these kids had neglected club feet. They got to the point where they were kind of beyond Ponseti casting, and Ponseti casting hadn't really been introduced yet at that time to Ecuador. And so immediately we started talking up, conservative care, but we also were doing a lot of the clubfoot surgery then for these kids, for the older kids, and then try to develop the clubfoot program for the younger kids at the same time. So we kind of saw that the surgery program would help us actually develop some of these more important preventive programs, or at least early treatment programs. Same thing with the hips. We were doing a lot of 3, 4, 5-year-olds with dislocated hips. And we were hoping that, by helping them with that, they could start to think a little bit harder about earlier detection of hip dysplasia. Some of the cases were more reconstructive, like, bad Blount's disease, bad ortho type of things.
And what resources did the hospital have? Like, what was the process of assessing? Because you have the article in 2019 about building the spine program there. So I guess what was the origin of that idea, and what were the initial stages and steps before it actually started materializing?
We started working in Ecuador in 2002, and as we started building this general pediatric orthopedic program, they had some very talented surgeons, and so they took on clubfoot really quickly. They got very good at hip dysplasia, because that was kind of the goal, is we wanted to train them or help train them, so we would scrub with them and have lots of cases together. That was kind of the initial goal, was to just get them capable so they wouldn't have to depend on us. And then as we got more into it, they said, well, we can do all these other things, but what we really need is spine. Because they had just a lot of neglected spine surgery, and these kids just couldn't get care anywhere. And so we sat down with them, and it seemed to me a really good opportunity, because we told them that if you want to have spine, you got to have a capable ICU that's working. Your sterile processing has to be quality. You have to have good radiology. You have to have a good blood bank. You have to have cell saver, intraoperative monitoring. They kept telling us all these things you have to have. And we spent about 2 years working with them, and we brought down one of our sterile processing people from our hospital. She's from Nicaragua originally, and she came in. She just totally reorganized their whole sterile processing program for the hospital, until she was convinced that it was good enough for spine surgery.
You did that before you actually started doing any spine surgery.
Yeah, we kept telling them that we're not going to do spine surgery here. We're not going to have we'll develop a program, but we're not going to do spine surgery until all these things were in place. And they said, yeah, we'll do it. And they actually started doing this stuff. We've never had a spine infection. It's because of what Lorenza was able to accomplish with their sterile processing people. And the influence she had for the whole hospital was tremendous, because the systems she put in place, the whole hospital uses, and so their infection rate is very, very low. But they were motivated at the time because they really wanted a spine program.
The thing that I'm hearing from you is that they approached you to help build a spine program, not you approached them. So
yes,
really an organic ask from people at the Children's Hospital there, as opposed to you trying to say, hey, here's a vision, we want to do a spine program, do you guys want us to do that? I mean,
exactly.
It sounds like a really good setup, that it was asked for, like they wanted that.
Exactly, because my experience when I worked on the Navajo reservation was I was trying to build a program there that they didn't seem to want, and it didn't work.
Right.
I don't want to do that anymore. I don't want to like have a vision of that and try to sell it to people because I don't think that works. I think you have to start with the relationships. You build the trust, and we were very fortunate because these people, the surgeons, were willing to trust us. We didn't have to convince them. But as the relationship built up and the trust built, they wanted spine. And it was like, okay. And, I'm okay. I really like doing spine surgery, but I didn't want to do it there if it wasn't done safely. And so I think they had something that they needed and wanted, and we had something to offer them. But we weren't so like convinced that we wanted to do spine surgery that we just felt like we had to like sacrifice quality. So we set up these standards and timelines and stuff. And so it worked out really well that everything that we asked them to accomplish, they accomplished. Oh, the one thing they didn't accomplish was they didn't hire a spine surgeon. We really wanted them to hire somebody, but they just didn't have the resources for that. So that was an early problem.
Who were the people that you were having those discussions with in terms of initiating a program? Was it the hospital administration? Was it the surgeons that were there?
It was the chief of orthopedics. It was Dr. Valenzuela, the chief of surgical services, who really pretty much ran that aspect of the hospital. And it was really kind of some of the other orthopedic surgeons there that wanted to do this. And of course, we had to convince the people within Project Perfect World, the board, that this was part of our mission, was infrastructure building, because that's always been a big part of our vision in this NGO, is building infrastructure and education together. We thought they were both important. So the spine thing, I think, was a good example of how we do both of those.
And in terms of infrastructure, what other things did you have to put into place, or what other things have you helped to institute in terms of processes or physical infrastructure at the hospital there?
When we started doing the spine surgery, we did have to bring a lot of people over. So we would have to bring over our anesthesiologists. So while we were there, we were doing hands-on training with their anesthesia for how to do anesthesia spine surgery. We brought over our orthotics person because we were seeing a lot of kids with scoliosis that wasn't surgical, that was bracing. And so they started a brace program there and actually helped the hospital build a beautiful new building, brace shop with trained people. So that came out of that whole spine thing, was the orthotics program. That was a whole infrastructure that wasn't there before. We set up an OR table. We brought over ICU. Our ICU people are from Dartmouth, and they're very, really quality. And they come in, every time they come on these trips, they've trained their ICU physicians and nurses in perioperative management. And so the relationships are well established. They look forward to coming back and seeing each other again. That was the basic infrastructure. And then just identifying children that had needs for surgery and then making sure that the prepared beforehand. So we had good relationships with the doctors there to get the kids ready for surgery.
And so what's the preoperative workup like? And who does that? And how are you guys involved? And, when do you find out about the kids? How much is advance notice and how much discussion do you have before you get there?
So we have a priority list. And so we use a REDCap database, and we have a priority list. And we'll see kids in the clinic, and we try to generate a surgery list the year before. So we kind of have this policy or principle that we don't see a kid and recommend surgery that week, because we feel it's really not good informed consent if these families are coming in desperate and they see this as their only chance to have an operation. So we won't schedule somebody the first time we see them. So if we see them, if they really need surgery, we'll try to put it off a whole year. Now, sometimes it doesn't work that way, but we'll try to put it off a whole year. And then at the end of let's say we have a trip, at the end of a week, we'll try to set a priority list for the following year, like who comes in first the next Sunday. And then if they need a workup during the year, if they need MRI or whatever it is that they need as part of their workup, pulmonary evaluation, cardiac evaluation, the local physicians we work with will will do all that and communicate with us during the year that the child's ready. And so by the time we come to a surgical trip, we pretty much know who we're going to see first, second, third, first priority for the week for surgery. Now we have a local spine surgeon who's there, who's now fully trained up, and he's helping to select the cases that he feels that he needs help with.
And what cases does he save for you guys?
So it'll be like the more extreme deformities that need really quality neurological monitoring, because we'll be bringing our own technician that trains their technician.
They have neuromonitoring there?
They can get it from the community. It costs money, so they have to be selective about who they use it for. That's a challenge for them. We've been bringing the same technician for many years now, and when he comes, he trains the person they use. Say you have 100-some degree curve that you think might be running into monitoring problems, we'll save those for when we're there. There's some of just the more complex stuff, congenital scoliosis. Sometimes he'll have some of the more extreme kids, he'll put them in traction for a month, and then we'll help them with it when we get there.
And were you doing those complex cases? So from my understanding, it sounds like it's more recent that a spine surgeon was hired. Before that, there wasn't a dedicated spine surgeon there. So when you guys were doing the first cases that you started with, were they, I'm guessing they weren't vertebral column resections on year one. What did you start with?
So it's a case that's not going to be like super high risk that you think, it might be like just a posterior hemivertebra that just needs to be removed or something. We really try to early on in the first couple of years to take less severe cases, but these ended up being kind of big curves anyway, just figure adolescent idiopathic kind of scoliosis, basically healthier patients. So we didn't want to cause any problems.
From your paper, it sounds like there haven't been many complications, but what would be the plan if something came up, a week or two or a month after you guys had come back home?
Every child that we operate on has a surgeon identified as their surgeon. So technically, it would have to be that surgeon having to deal with that complication, which I guess by that point, the major one would be a spine infection that has to be washed out. And they felt comfortable with that. For instance, we did have one major complication. We had a girl that had neurofibromatosis, and we did an anterior-posterior surgery the same day. I think because of it was a long surgery, she got a somewhat coagulopathic post-op, which didn't get corrected properly, or as much as we should have corrected it. By day 3, she started developing delayed paralysis, paraplegia. And so we realized that we didn't have any contrast material to do myelogram. She had a rib in her canal that we left alone because it was up high and it didn't seem to be bothering anything. And we were wondering we didn't know if that was the cause of her delayed paralysis or what it was. And so it took us a few hours to find some contrast material because we had to look around the city for it. So we realized that was one thing that we hadn't paid any attention to, is what are you going to do if you have an acute problem like that? So we did a myelogram, and she had a block kind of in the middle of the apex of the curve, and it just turned, so we took her back, and it turned out to be just a delayed hematoma that we irrigated, and she recovered, but it was kind of scary to think that we had created this problem that we didn't need to. Fortunately, we were still there to take care of that problem. She was done earlier in the week, just with that anticipation. If she had any complications, we'd be around to help take care of it. Fortunately, by the time we took care of her, we had the spine surgeons were there. I think that's a really important, valuable lesson for me is how important it is to have local people that will take co-ownership of the patient with you, so you're not leaving these problems behind.
From an education standpoint, what kind of things do you do to help, with the education component for the surgeons that are there?
Early in the program, we identified one of the surgeons there that was interested in taking on spine surgery. So he had some training in spine, and we managed to get him a scholarship through SRS funding to come to New York, and he spent a few months with Dr. Boachi. And he came back and started working for a little while. It didn't work out because I think in some of the Latin American countries, if you're not paid real well, you start looking for work, outside work. And he started looking for other work to help support his family. And then once he started getting busy with the better paying work, then he wasn't available for the children's hospital anymore. So the hospital realized that if they're going to have a spine surgeon, they need to pay them properly. So the most important part of our education for them is to get them in the OR with us and work side by side with them on the patient, really focus on operative techniques. And we would have daily indications conference with them. We go over the cases for the day. We always have an end of the week compilation where the residents put together all the cases and the x-rays, and we just spend a few hours just going over the cases, what we learned from them. So that's kind of the essence of the education.
In terms of roadblocks or setbacks, what kind of building the program, what kind of setbacks have you had?
COVID. Because it's been 2 years now since we've been able to go. And so we've been communicating with the doctors there, but that's been a huge setback. And then 1 year we had to kind of delay a trip because of a volcano erupting. So I think the biggest thing, though, is kind of externals that you don't have control over. There's been, internal changes within the hospital leadership and within the organizational board that's been challenging, and then the politics of Ecuador. But we've managed to kind of weather that. But COVID really set us back. And we're going to go in August to do just a exploratory trip because we don't want to get back to business as usual until we sit down with them and make sure that we're not being a burden to them by bringing on new surgical cases until we're sure that they're ready for that. So we're going to visit in August, and then I think our next trip is going to be in January.
It's interesting. I mean, it seems like throughout the process, you guys have really done a needs assessment, and it's been based on the host hospital and host surgeons in terms of what they perceive the needs to be, and did what they asked. And I think that seems to be, at least that, from my perspective, seems to be one of the key principles, is like a needs assessment, and where the host country or host hospital and host surgeons have a major role in sort of guiding the direction of the program.
Absolutely. If you can get yourself in a situation where they're asking for your help, then all you have to do is ask the hard questions so that you're making sure that you're helping them in a way that makes sense. We have, certain principles that we try to follow. One of the first principles is that we're their guests. And so we have to act like guests and, be respectful of the rules. They have certain rules, like you can't leave the OR without changing your scrubs. Once you wear your scrubs out of the OR, you can't go back in. We're kind of lax in our country, but they're very strict about that. So we follow the rules. Some of our principles is if somebody on the team sees something that's not right, it's your responsibility to speak out. We're not giving you permission to. You have to speak out, and it's expected. And safety always. Everything has to be done safely. So if somebody in the team, if there's one person on the team that doesn't think that a surgery should be done for whatever reason, the kid's not healthy enough or it's not safe, they're expected to speak out, and then we won't do the surgery until it's resolved. And then, of course, long-term relationships, and that whole concept of informed patient consent. We really want to make sure that the family's properly informed in a way that's culturally sensitive, really gives them information. And it has to be patient-centered, and they really, truly have to be consenting. And in these international programs, it's really easy to go and just recommend some crazy surgery, and the family is like desperate to help their child because they care about their child, but this might be their only opportunity. So that's not really informed consent. If you just show up one day and tell them they're going to do surgery the next day, of course they're going to agree. We hit a milestone 1 year because after we spent all this time talking to the family, they decided not to have the surgery. And it's the first time that ever happened to us. And we were so thrilled that a family actually realized that the risks were too high and they didn't want to do it. And we thought that was a real major accomplishment.
Well, it means your informed consent process is, is legitimate and is really an informed consent.
Yeah, it's working.
Or participating.
Yeah, and we kept seeing that kid back every year for a couple of years. Not that we wanted to try to talk them into surgery, but we wanted to give the parent an opportunity to think the process through if they wanted to change their mind. And we kept reassuring them that we're not trying to do surgery on your child. We just wanting you to make the right decision for your child. And they ended up after a couple of years still saying no.
Do you think the year-long wait, at least that you guys attempt to wait a year, do you think that makes a difference?
It certainly gives them a chance to think about it and make sure they want it. But I think it takes the urgency away because they have to go away. I don't know, maybe sometimes they're just feeling like, okay, I'm going to wait a year and let's do this surgery. I don't know, it makes me feel good. It makes me feel like I'm at least being more thoughtful about these cases. And, and just before we go on a surgical trip, we have to go through and we go through our notes and we make sure that the priority list has been reviewed by everybody. These are the kids that we're going to consider surgery for. Maybe it's good for us instead of the family. And then the last principle I always tell everybody is we're replaceable. So we have to be constantly training our young people who are going to replace us. So like when we have our trips, we try to always have new people on the trip. Same thing when everybody that we interact with there, we're trying to provide as much training as we can for them.
Maybe even the goal of working yourself out of a job, not necessarily being necessary to even go with the spine surgeon there.
Yeah, that would be ideal. Like for instance, someday what I would like to do with this program, show up a few times, just myself, and just scrub with the surgeon because he's looking for some collegial interaction. Gone to Nepal quite a few times also. I didn't want to get into that because we're talking about Ecuador, but Vivek Spenskota, who is at HRDC in Nepal, I've done that with him now a few times. We have some colleagues in eastern Ukraine that I've gone a few times. I've been very fortunate. They've invited me to come and just scrub with them. I do have an interest in the hip, and so in both of those places, they really wanted to develop a hip preservation program. And so I agreed to come and we would do cases together. That was good. And then
that was just you, and the staff otherwise was from the hospital there.
Yeah, it was just me.
Right.
And after going a few times, they don't need me anymore. It's great because I see them at meetings and stuff, and they're like doing just fine. That's the ultimate, because some places are so well established that the infrastructure is there. They don't need that. They just need a colleague to come and work with them.
Do you think there are other situations though where surgeons have the skill, but it's really more of a resource issue, meaning access to neuromonitoring, access to implants, things like that?
Ecuador is definitely that way. The surgeons there now have the skill because they've gone out and get good training, but there's an economic factor there for spine. There's certain families that can afford it, but that's probably only 10% of the population. It's the other 90% they just can't. They cannot afford it. The implants are too expensive. The neuromonitoring would cost money to have, and so those patients really need some sort of support. We've been fortunate because Cerner is based in Kansas City. They have a foundation called First Hand. One of their missions in their foundation is to provide direct care for children. In this country, kids get direct care because they've got insurance. So that program is looking for children to fund. The fact that we plan out a year ahead of time, we've been able to then give them a list of all the cases that we're going to be doing. And they've been able to give us the funding that's needed to get these kids in the hospital because it costs like $2,000 to do a spine surgery.
So the cost there is $2,000, and that's implants, or the implants are donated?
No, the implants are donated. So we bring the implants when we go. We bring the implants, but the cost of getting the child into the hospital, the radiology costs, blood bank, ICU costs, because the hospital requires these kids to go to the ICU, and then the postoperative care, all the meds and everything else. So in and out for a spine surgery, they're in the hospital 5 days or so. It's $2,000, and that's a amount that a family just could not afford in Ecuador. But that's the cost of that's what the hospital charges. I assume that's what it costs to run the hospital for a patient. And so that's one of the benefits of the program is we can bring kids in that otherwise wouldn't have been able to get that care anywhere.
What do you think moving forward is the answer for resource-driven access issues in low and middle income countries? Say, for example, the issue of implants. Because now, like, say, for example, you guys go on a trip, you find a partner company who will donate implants for that trip. From a sustainability standpoint, if the goal is for the spine surgeon or the surgeon that's, the host surgeon from the host hospital, it's the way forward in terms of providing a more constant stream of implants so that they'd be able to do surgeries outside of a trip.
People do it differently in different places. Like my colleagues in Ukraine, they have locally made implants, and so a pedicle screw would be $100, whereas it's much more expensive. And what they do is they write a prescription and give it to the family and tell them exactly what implants to buy, and the family goes off to the local dealer and buys the implants. So it's a little bit more affordable for the average person in Ukraine that needs spine surgery. But the surgeon has to know exactly how many screws and what size they're going to use for that particular case.
Yeah, pre-op template.
Template. It's funny because I've learned to do that here. So
sure.
we do that for our cases now. We tell or give our scrub a few days in advance what screws we're going to use, and then they just process those little tray of screws instead of trays in the back. And we just use the screws that we've pre-templated. I think if Ecuador is going to have a sustainable program, they probably would have to have either locally made implants or some manufacturer in South America that can make them relatively cheaply. And then, but they'd still be out of reach to a lot of families. And so some of the poor kids are going to need to have subsidized care if they really want to take care of their whole population. Now, for instance, Ecuador has a lot of tourism. They have a lot of different industries, like, they export chocolate, they export oil and gas. The nature of their environment, they have a lot of stuff going for them that they would just capitalize on that and then utilize that for their less advantaged kids. And I see some of that happening. They're starting to have more government funding of some of their programs. Maybe that would be an ultimate solution so that you don't have to depend on NGO type of funding for kids.
Is that on the horizon for Project Perfect World to start reaching out to the government there?
We haven't been talking to the government so much, although I think the current president has a more favorable outlook to this type of thing. But we've been working with the junta that runs the hospital that we work in, trying to barter with them, where we provide containers full of medical equipment that comes from the United States or in other countries, just like used equipment or just excess equipment. And we've been sending that over to them, and in exchange for that, then the hospital agrees to take care of a certain number of kids if they're going to get this supplies. And so that's kind of one solution where it's a way of providing care for those children where they don't have to pay for themselves, but the hospital is not having to pay for it either because they're getting something in return from excess that's coming from another country.
Question about surgical indications. Are there cases that shouldn't be done in certain environments based on matching the resources of a hospital, to the complexity of a case? And have you guys run into that? And how do you guys work through that?
I think there's certain spine cases that you have to be really, really careful about taking on in that environment. What I've learned is you have to be really sure that the local surgeon can handle the complications that you leave behind. And that's really challenging because right now the spine surgeon that's there wants to do the more complicated cases with us. because they're more challenging, but he's got to be willing to take care of the complication that comes out of it. Our biggest challenge has been the cardiac kids. There's some kids that their heart's just not healthy enough for surgery, and we refuse to do surgery on them unless their heart was corrected first. And if they can't get the heart operation they need, it doesn't make sense to do the spine surgery. I think we had early on, we had one child that we didn't realize that. We put them to sleep first, the spine surgery, and they just weren't doing very well even before we made the incision. We just decided it wasn't the right thing to do, and so we stopped. But that's kind of why we have that policy that if somebody doesn't feel that the surgery should be done, and it's typically the anesthesiologist. John Sanders is our chief anesthesia person that comes, and he's been really good about saying, no, this child shouldn't be done, and that we just don't do it. It's unfortunate, but.
And what about anesthesia there? How involved are they in the program?
Very much so. So they're very collegial with us, and so the anesthesiologist gets the list of the kids that are on the schedule, and they have a say in which kids are going to get on the schedule. So they're reviewing that way in advance, and so they know who the kids are. And then when it's the week of the trip, they're there on Sunday when we're evaluating the children. They will speak out if they see something that's not right.
But let's say there's somebody in the SRS who really wants to get involved. They sort of have it on their heart, but they're not quite sure how to get plugged in. That call's just not coming. What should they do? What would you tell them?
They want to do spine surgery?
Yeah, or spine education, or work on resource building towards a spine program in a low or middle income country.
There's a lot of programs out there. If they just got connected to the right people, they could just go and spend a week with somebody that's already doing it. Like the spine surgeon that's in Nepal, I think he's getting pretty busy with cases, and if somebody wanted to go and just scrub with them, I think that'd be a good place to start. Because that way you're not trying to develop a program or push yourself into something that is not fully cooked yet. And there's probably a lot of places all over the world where there's good surgeons if you wanted to just connect with them and just learn from them. Kind of like what I did in Liberia. I was in Wambatar at Ganga Hospital last year. I was a visiting professor there. And it was an amazing place. They just do all kinds of incredible work. Dr. Heffernan, who's there, he's like world renowned in tuberculosis surgery. He was awesome. He got such a great experience. And so I guess if I was wanting to go do spine work, I think I would rather, instead of trying to do it myself, I'd probably want to go and work with, observe somebody or scrub with somebody that's like a master at it.
You would find somebody in a different country who was doing that and reach out to them to see if you could come and visit.
Yeah, I think that would probably be a better way than trying to think that you're going to do spine surgery on kids that there's not even a program. I think you need to go to something that's well established instead of trying to do it yourself. To think that you're going to go and start a spine program somewhere, I think that's a big leap. The easiest thing is to go where something's just really well run. And these once a year trips are, I think, a little more challenging because they may not need somebody. And also, I think at that stage in your career, you got to be real careful to take on. You don't want to take on things that are too challenging. You have to have a lot of sense about what you're capable of doing. Like I've been really fortunate in Ecuador, Steve Santora, who's just a really great guy. He's at the Salt Lake Shrine, and he's got a wealth of experience. He's very practical, and he's been coming with me for many years now. And so we both are kind of at the same stage where we've been doing this for a while, but he's a little bit wiser than me. He's like just more conservative, and he's just a very thoughtful person. And so I've been really lucky to have something like that. So I guess if you're young and you're looking for something, just make sure there's somebody older than you that's there. Yeah. That you're not
the most experienced person if you're if you're early in your career.
Yeah, if you're the most experienced person there, you're probably in trouble.
What other ethical principles do you think people should consider before they start getting involved in global outreach?
The ethical principle, I think, gets back to informed patient consent. It's got to be patient-centered, and they've got to be informed, and they've got to be consent properly. And that's a really complex concept, is how to deliver that properly, because some of the ethics of it is you got to provide them a good, solid program so that you don't want to be harming anybody. I think one of the things, though, is, you got to focus on training those people. It's their place. You're just a guest there. I think you got to focus on the preventative part of it as well, not just going there and doing surgery, but how can we help provide a better early identification program, early screening? Can we see these kids earlier and get them into braces and help them develop that part of it and not just do surgery?
What are your thoughts on that? I think it's really interesting that you guys help build an orthotic program. How do they sustain that in terms of materials? And it sounds like they have trained orthotists, but in terms of the materials and the cost of that, how does that work?
Well, when we send containers over there, we'll continue to send, lots of material that the hospital uses. The expectation is that they'll provide direct care for children that need it. Our orthotist from our hospital, Brian Curl, who's been going down since 2008 with us, and his brother goes down as well. And they've been just passionate about building that orthotics program. And so they've had a bunch of people that they've trained and have gone away for training and have come to the United States for training and gone back. And so they've developed the ability to do spine braces there, provide that service. It's still a challenge to get kids in early enough with early identification. There's still not that awareness in the country.
What do you think that would take?
More education of the primary care doctors. You can brace scoliosis. I don't think that's really well known down there. But they do see kids that are at a good stage that they get braced, and so if they catch them at the right time, they've been able to brace them. But I think the orthotics has been tremendous. It's not just spine braces; it's leg braces and prosthetics in particular. When somebody has an amputation, they just absolutely need a good prosthesis, and so that program's also developed to provide that as well. So I guess what I'm saying is, it's not just about spine; it's about disabilities. What's the burden of disease for children in general? But spine's just one part of it. Clubfoot, DDH, which they're all part of the burden. But we as surgeons, when we go down, we need to be kind of aware of all that stuff. Is okay, if we're going to see kids that need spine braces, okay, well, maybe this is an advantage, an opportunity to help them with their infrastructure and education for orthotics in general. And maybe that can be then, and it has, I think, become a revenue stream for the hospital. Is okay, they get a reputation for a place that makes braces, so people from all over the region can come in and get their brace made. And of course, some of them can afford to pay for it, and that helps fund it.
What about societies? What role should, for example, the SRS play in this?
Setting standards for quality safety, the OR, making sure that they have a proper preoperative checklist, that everybody is aware of the intraoperative monitoring checklist when something happens. What's the minimum training for surgeon out there, so that people are at least aware that there's some sort of fellowship expectation for training? How long should it take? Just things like standards for resources like intraoperative monitoring, just an awareness of that as a standard of care, so that it's not just a neglected part of the surgery. I think SRS has also been great about scholarships with their outreach program for that, and then also good outcomes research. Because I think the outcomes that we expect in our country, people need to start thinking also that they should be following their outcomes as well. It'd be great if every surgeon could then contribute to the SRS M&M list every year, so that they can become part of some sort of registry.
Is there a separate registry for the SRS GOP sites?
I'm not aware of that. We keep a database of all the cases we do, and we keep our registry in REDCap. We keep track of any things like complications. We don't have a good way of tracking things like SRS-22 outcomes, although we did it for when we try to study our spine patients, but we don't really routinely do it, which we probably, I think, would be a good thing to do.
Have you found it difficult to keep track of all of that and to do was it tough to get people to come back for the SRS-22 when you tried to do that in, I think that was 2016, 2017?
No, that wasn't too hard because it's a small country, and so everybody has cell phones. And so it was easy when we asked them to come back or an evaluation, they would just come back. I think it's more just, we just have to make that part of our priority. If we're going to run a program, it's like, make sure you're checking the outcomes on what you're doing. Are you really making a difference?
I know I've taken a lot of your time, and
I hope I'm not wearing you out.
No. Any final thoughts?
No, this has been really good to kind of try to explain, at least my perspective on this whole thing. I do think that the way we went about it is not necessarily the way other places might go about it, but I think that there's a big advantage to starting small with, if you want to develop a program. I mean, if you're a young person, it's great if the program's already developed, but if you want to start a program, or you have to really start with the relationships and start with mutual trust. It really has to be their program that they want. I mean, you have a say in how things like safety and how it's run, but they have to be asking for it. Otherwise, it's very frustrating to have an internal vision and think you're going to be able to convince other people about your vision.
That's one of the key things I think I picked up from this was that you had the one experience where you tried to cast this vision that wasn't necessarily wanted in that location. And then in Ecuador, you were asked to develop this program, and then therefore it's been successful. It's pretty telling. It's a really good point.
And the other thing I forgot to mention is, this is really important, is we have a lot of good people that are doing this work now. Our anesthesia folks, our ICU people. So these are all volunteer people. The people on the ground in Ecuador, Sister Annie, her people, she's got lots of people, the doctors there. So it's a whole community of people that have a shared interest in helping these children. And I think we communicate a lot, and everybody enjoys each other and trusts each other. And I think it's those relationships that make it enjoyable, but also make it possible to do this. We haven't been able to go there for 2 years now, and we're just now starting up again. But the doctors that we met in 2002 are still there. They don't go anywhere. Ecuador is like this island. It's been tremendous that they've seen us through this whole program. They're the same people, and we just have known them for 20 years now. Yeah, every once in a while, they'll have a thing at Posna where they ask the old people, like, what's the most meaningful thing in your career or in your life? They always say the same thing. My family, my friends, my professional relationships. They don't talk about the cool surgery they did. They talk about the people that they've come into their lives and influenced them. It's absolutely true. Because I've seen that in all these different programs I've been involved with, is these friendships you make in your life. That's my last thought, is the teamwork that happens and the togetherness that comes out of all this.
I think that's a good last thought. And I appreciate you taking the time to share with us and give us your insight and speak about not only the program in Ecuador, but just a little bit about all these little stops that you've made along the way and all this knowledge that you've gained. It's been really fun for me, and I really appreciate it.
Nice to talk to you. It's been great.
Wow, that was such a great episode. I really enjoyed the topic, and I really love the speakers. They are such a dynamic group. If you enjoyed this episode and want to hear more episodes like that, please stay tuned for our future podcast episodes, because we have a lot of great content coming.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit SRS.org for further information.